Welcome back to the KDPG Sunday edition. Our guest this morning is Dr. Amish Adalja. He is the senior scholar at the Johns Hopkins University Center for Health Security, and they recently released a study about the public health issues of flu outbreaks and perhaps what else can happen as far as a pandemic that could affect the world. We were just talking about the difficulties in coming up with a universal vaccine. I want to go back to that for just a moment. You say part of the problem is that the vaccine or the viruses keep changing. They mutate here or there. Is there not a part of the virus itself that you can find that doesn't change with all of them that you could use to try to attack them?
That's a scientific question that people have probably solved now. There are parts that don't change, and that's what these new vaccines that are going into clinical trials, very early stage, that are targeting these parts of the virus that don't vary, that are the same, and hopefully that will lead to a universal flu vaccine in several years. Vaccines, the development of vaccines is measured in decades, not in years. It's not like in the movie Contagion, before the credits roll, you have a vaccine. This is something that takes some time.
What about in the last flu season, people over the age of 65 are given a more powerful flu shot? What happens with that, and why don't we give that to the entire population? Well,
we know that people that in a flu season, deaths usually are the very young and the very old. So we target better vaccines to the elderly to boost their immunity, because their immune system after the age of 65 starts to basically not respond as well to the normal vaccine. So what we do in the elderly is give them a high-dose flu vaccine or a flu vaccine that's got another chemical in it called an adjuvant that boosts the immune response. And there is an argument to be made that we should probably do that to more people, that's a better flu vaccine. However, the data is the strongest in the elderly population, who really bear the brunt of a flu season.
All right. Doctor, how much salad have you been eating these days?
Not so much after the romaine E. coli outbreak.
Talk to us a little bit about that. What should we be worried about? How long should we be worried? What sort of things should we think about?
So this outbreak is probably over now because everything expired and hopefully got thrown out. But what happened there was we had some contamination of romaine lettuce that was grown in the Yuma, Arizona area, which is the place where the United States grows romaine lettuce during the winter months. We still don't know how this E. coli strain got into it, but it did sicken people in multiple states. Pennsylvania was probably the second most affected states, and we had a death from it. And this is a particular strain of E. coli that produces a toxin that can lead to kidney failure and the need for dialysis and death. And I think this really underscores the need to get better with food security, that we can't trace these outbreaks.
I just want to ask you this question, because I don't know. Is the E. coli in the lettuce itself? Is it on the top of the lettuce? Can you wash it away, or how do you know?
It could be contaminated from the soil that may be used for fertilization. It may not have came off. It could be contaminated when somebody is putting the lettuce. It's on their hands and they're putting it into the bags. So it's really unclear at this point still how this outbreak started, and that's the challenge of foodborne outbreaks.
Is it possible to figure that out? How would you be able to figure that out?
Really going back and tracing where the cases were, what people had in common, where the original source was, and what kind of products they were using. Were they all eating at restaurants, or were they all buying bag lettuce from a certain grocery store, and then kind of tracing it back, almost like a detective.
Well, say they were all buying from the same grocery store. What would that tell you?
It might tell you that supplier that grocery store buys from had the problem. So that contamination might have been in packaging at that manufacturer.
Okay, so say you've determined that. What's the next thing you look for?
You go there and you look at all the plant's operations and see where the breakdown in safety occurred, because this is something that shouldn't happen. And then you try and figure out ways to correct it.
But could that have been a case of personal sanitation?
It could have been a case of personal.
You'll never be able to figure that out, right?
Well, you can actually look at people and see if they're colonized with this E. coli, see if they had symptoms. Anybody at that place might have had symptoms, didn't report them, that kind of thing you can look at to try and figure out where it came from.
That's an interesting part you just brought up about reporting that. How long does it take for an outbreak like that to finally reach the CDC and they start to sound an alarm on that?
Well, these E. coli outbreaks are reportable to the public health agency. So if a case of this happened in Allegheny County, for example, it would go to the Allegheny County Health Department, who would report it up.
I go to my doctor. Is he going to necessarily know, he or she going to necessarily know right away that it's E. coli?
No, they may not. And I think that's why it's important that clinicians be very astute and keep aware of outbreaks. The way they follow sports team scores, you need to think about outbreaks all over the country, all over the world that way. Because if we miss these things, they can magnify. And what ends up happening with these E. coli things is it takes a couple cases for people to knit this together and say, hey, this is an outbreak, and then sequence the bacteria and look and see that, oh, this is genetically identical. This is a common source outbreak. We have a big E. coli outbreak on our hands. That does take time. We've gotten much better at doing it, but it is something that still takes a lot more time.
If someone is infected with E. coli, David might be infected, I might be infected, will our reactions possibly differ, or is it going to be the same no matter what?
With any infectious disease, there's a spectrum of illness. Some people don't get sick at all, some people get very sick. There's a lot of genetic differences in your immune response to infections that basically individualize an infection. There's some general principles, but some people may have an infection and have no symptoms at all.
All right, we talk about the flu virus, we talk about the E. coli. There's another issue going on in Africa which has popped up again, the second time in less than 5 or 10 years. That's the Ebola outbreak. How dangerous is that for those countries right now?
For the DRC.
And for the rest of us, since, as you already pointed out, you know, the world has shrunk.
So Ebola is a deadly disease, a frightening disease, but it's not a very contagious disease. The DRC has had this is its 9th Ebola outbreak. Ebola is something that is very challenging for countries that have poor resources to control, especially when it spreads into the urban area. We've probably got about 50 or so cases right now in the DRC, but we know that the DRC is adept at dealing with this. It's still going to take weeks or months to control, but you can control Ebola by finding patients, putting them in the hospital, isolating their contacts, tracing back all of their contacts, changing burial practices, which is one way that people spread Ebola because they bathe the bodies that die with their bare hands, and really getting this kind of basic on-the-ground public health measures in place. That usually stops it. And this time we have the advantage of having a vaccine as well, so that may change the way we manage this outbreak.
So on Wednesday in West Virginia, there was a death due to hepatitis A. What's that telling us, and how serious is that? I mean, it's obviously serious for that person, but...
What we're seeing is a major resurgence in hepatitis A in the United States. Hepatitis A vaccination became routine for children in around 2006, so there is a big swath of the population that's not protected against hepatitis A. And what we saw was basically outbreaks starting in California, basically in the homeless population, kind of spreading across the country into Appalachia, into Kentucky, into West Virginia. And hepatitis A, for most people, isn't deadly, but if you've got other underlying conditions, so maybe you have hepatitis C, which we're in the middle of an epidemic of hepatitis C in this country. If you have alcoholic liver disease, hepatitis A can kill you. So it's really important that we act aggressively to stop these hepatitis A outbreaks with vaccination.
So does West Virginia constitute one death constitute an outbreak, or is it just a simple isolated case? Or
one case probably is not an outbreak. If you see more cases after that, I think we could have an outbreak in
so what should people in West Virginia be looking for, the health authorities there?
They should be looking at how this person got hepatitis A. Was he eating at a restaurant? Was it someone that was homeless and was exposed to other people's fecal matter? Where did this case occur? So you really have to be almost like a detective investigating a murder. Who, what, when, where, and how. Just trying to figure out how that person came into contact with the virus, and then understanding who they were in contact with, who they might have spread it to, and then giving people vaccine that might have been exposed.
I want to go back to something we started the program with, and both of you are historians, and you know the results of this, but in 1918, when the flu pandemic hit at that point, you say that there were anywhere up to 50 million people worldwide who died. If we had a pandemic now that you're afraid could be happening, or could happen, I should say, not is happening, what's your projections on death tolls at that point?
In many ways, I think it could be worse because the world is smaller. We've got mega cities. We've got, war and strife in a place at a scale that we haven't had in the past. You've got cholera raging in Yemen. We've got in South Sudan a big civil war where people can't get their HIV medications. We know that the conditions of the world today are very ripe for a pandemic in a way that they weren't in 1918. Like I said earlier, you can go from Pittsburgh to Kinshasa within a day, and you can be back with whatever infectious disease you might have contracted. So I do think that in that sense, the world is much, much more smaller and much more conducive to pandemics. We know that infectious disease really started when humans started to settle in high population density. And if you look at the number of megacities all over the world, it's really astronomical.
So another advantage of Pittsburgh's poor air service, I suppose. Huh?
Maybe that's true.
Yeah. But in the days where people crowded into ships, immigrants, settlers, etc., disease was a huge issue, and of course the Native American population suffered terribly from that, correct?
Right, but the thing about a ship is that if most of the time you got sick and you died on the ship.
Right.
And you don't do that anymore because the incubation periods are longer than travel times. So when you're taking a ship from England to the United States or from Africa to the United States, you would get sick on the ship and you would die on the ship, and there would be less risk to people. However, here, people come here and they land just like the guy that had Ebola in Dallas did. He landed here, he wasn't sick, he got sick in the United States and infected 2 other people. This is a function of the fact that our travel times have gotten so much shorter and incubation times are much longer than travel times.
We only have about a minute left here, and I want to get into this and out of it quickly as we can. When the polio virus was hitting everyone across the country, and then the vaccine was made. It was done privately, March of Dimes, that sort of thing. But you and others say that the government has to now be involved in this sort of thing, as far as, especially with the flu.
What's happened is most of science is now funded by the NIH. Private companies have basically been crowded out. There are some that are involved in the vaccine space, but the markets for some of these emerging infectious diseases are very, very small. It's not the same thing as making a cholesterol drug or even making a vaccine against, HPV. This is something very targeted. These countries that have these diseases don't have the money to afford these. And the other point is that most of these are national security threats, and you have to think of these vaccines and countermeasures the same way we think about missiles, because many of these are biological weapons, many of these can be weaponized. This is a national security threat, and infectious disease has to be thought of in those terms, or we're not going to be safe from the threat of infectious disease.
Doctor, thanks so much for being with us this morning on the KDPG Sunday Edition. David, I'll be back with some final thoughts in just a moment.